We are one nation, one people. When called upon to give from within, we come together and find that our capacity to help others is limitless. Here, we are fearless. What lies inside all of us is more than data. It's life. It's more than insight and medical research. It's vision and honor and compassion. What's flowing through America's veins is its diversity. The next great breakthrough will be found in each and every one of us. And what we find there will unlock mysteries, heal the sick, and eradicate disease. We ask for 1 million individuals to come forward and stand on this landmark in history. We ask America to do, once again, what she has always done. Lead the way forward. We're one nation, one people, but all of us are different. And it's those very differences that will lead to answers for generations to come.
The pre-activity assessment is to establish baseline understanding of research and the All of Us program. The assessment takes approximately 2 minutes to complete. Please scan the QR code to complete the survey. Thank you. This presentation is an overview of the All of Us research program. There's a gap in medical research that only you can fill. The first step is to understand the concept of health research. Research is the process of finding out new things. Health research is the process of finding out new things about improving people's health care. Did you know that the majority of health research has been conducted with middle-aged Caucasian men as the participants? That means that the medicine or treatment resulting from that research is designed specifically for that demographic. Communities who are underrepresented in medical research then are at risk of experiencing negative responses because it's not the best for their body. Going forward, we need to do a better job of including all types of people in health research. The only way we can fix this injustice is with your help. So, what's the All of Us research program? All of Us is a program led by National Institutes of Health that actively work to improve healthcare through research. Unlike research studies that focus on one disease or one group of people, All of Us is building a diverse data set that can inform thousands of studies on a variety of health conditions. It's a long-running effort to gather the data from 1 million or more people living in the United States to accelerate research and improve health by taking into account individual differences in lifestyle, environment, and biological makeup. All of Us is the largest and most inclusive health research program ever. We're all different, right? But when we go to the doctor, our treatments are often the same. Your healthcare and treatment should be tailored for you. This is called precision medicine. Precision medicine is a new approach to improving health, treating disease, and finding cures. It acknowledges that a one-size-fits-all approach to medicine isn't the best, because we know that what works to treat me may not work to treat you. Each person is different. Factors that greatly impact our health are our genetics, our lifestyle, and even our environment. Ultimately, precision medicine can produce more accurate diagnosis, figure out earlier detection, and better prevention strategies and treatment choices. Precision medicine takes into account 3 factors: genetics, lifestyle, and environment. Some examples of precision medicine include prescription eyeglasses, blood transfusions, insulin pumps, and hearing aids. A growing body of research shows that centuries of racism in the United States has had a profound and negative impact on communities of color. The impact is pervasive and is deeply embedded into our society, affecting where one lives, learns, works, worships, plays. And it has created inequities in access to a range of social and economic benefits, such as housing, education, wealth, and employment. These conditions, often referred to as social determinants of health, are key drivers of health inequities within communities of color, placing those within these populations at greater risk for poor health outcomes. So, you want to know more information or even enroll? Visit the All of Us website at joinallofus.org/together. There you can learn more about the program or choose to sign up if you're ready today. Or you can download the All of Us Research app in the Google Play or Apple Store. You may notice there are 2 All of Us apps in your App Store. Please be sure to download the one named All of Us Research with an all-white background created by Care Evolution. Once you've loaded the site or downloaded the app, you can create your account. You will be asked to give your consent. This includes reviewing a series of videos which will provide more detailed information about the program. These describe all the types of information you may be asked to give. Once you feel comfortable that you know what to expect, and if you're ready to give your consent, you'll electronically sign the consent form. You can do all of this from your computer, tablet, or smartphone, or at a partner center. You may also elect to share your electronic health records, which is the digital version of your medical chart, and complete the consent to get DNA results. You will be asked to answer several health surveys. In combination with other health information, the answers provided in these surveys can help researchers identify patterns about how our lifestyle and background affect our health. After these initial steps, you may be asked to share your physical measurements and provide your biological samples so that the program can help researchers better understand how different factors, including our genetics, make our participants unique. Please go to the site and locate the Join Now button to create your account. This year, in collaboration with the All of Us Research Program, the BGLC created the Minority Student Research Symposium. The Minority Student Research Symposium, with the All of Us Research Program, invited underrepresented minorities to complete a research project using data from the All of Us Research Hub and present their work in a virtual poster session on Saturday, May 22nd, 2021. Greater participation of all racial and ethnic groups is needed in biomedical research. Underrepresented minorities represent over 30% of the U.S. population, but less than 9% of STEM PhD members and 7% of all physicians. We know that diversification of the biomedical workforce will help address the critical need the U.S. faces to reduce racial and ethnic health and healthcare disparities.
Good evening, everyone, and welcome to our first Black and White Table Talk. We have intentionally designed the Table Talk series as an interactive engagement featuring topics that enhance our community's resiliency on issues such as male breast cancer, Black mindfulness, Black girl magic, and Black boy joy. We are kicking off tonight's Table Talk with a compelling story of a male breast cancer survivor's journey.
Dallas man is sharing in their fight. He shared a story with health and wellness reporter Sonia Azad, a man.
He is incredible. Such a great attitude. Breast cancer affects 1 in every 1,000 men, you guys. And that number has stayed pretty stable for the last 30 years. And we don't hear much about it unless a brave man like Clifford Armstead decides to speak up.
Oh, it didn't work out so well.
Clifford Armstead is a man's man.
That's Jesse Armstead, and that's Irique Armstead, plays for San Francisco.
The self-proclaimed cowboy and car fanatic was diagnosed with breast cancer after leakage from his left nipple.
It was traumatic going back to work with this information. In life, you never want to hear the C or the D word, which is cancer and divorce.
Clifford underwent a bilateral mastectomy to remove tissue from both breasts as well as his lymph nodes.
I was cut from here under both arms, and I was wrapped up, and still today I still have to wear a wrap.
The 46-year-old also has family history. His mother lost her breast cancer battle at age 73.
It is the same as women and men.
Dr. Lashmi Kannan says breast cancers are not only passed down the same way in women and men, the disease manifests similarly in both genders. In men, she says, the BRCA2 mutations mean an even higher risk of developing breast and other cancers. Ways to stay ahead of it: genetic testing and self-exams.
Self-examination for men is exactly the same as it is for women. In fact, it is much more easier for a man because men tend not to have that much of a dense breast tissue.
Does your son understand what you're going through right now?
And he would ask me, "Hey, Dad, are you all right today? How are you feeling today?"
For now, Clifford is feeling just fine.
They say I'm clear.
His doctors are keeping an eye on his health,
Awesome!
while this soon-to-be grandfather has his sights set
Over there.
on another prize.
So I'm keeping the fingers crossed for the AC Shelby Cobra. Okay. That's what my wife promised me.
And I'd say he deserves it. Now, Clifford is very active in speaking out about breast cancer at churches and across this community. Methodist does host a men's breast cancer support group. They meet. I have information for you on my Facebook page. Sonia Azad, Channel 8 News.
All right.
Clifford Armstead's story was truly compelling and serves as a perfect segue to an interview with our first guest, Dr. Katisha Vance, a medical oncologist. Dr. Vance earned her Doctor of Medicine degree from the University of Alabama in May 2000. After residency, she completed subspecialty fellowship training in medical oncology and hematology at the University of Alabama in 2007. Since fellowship training, Dr. Vance has served patients in a successful private practice with Alabama Oncology, LLC, at Brookwood Baptist Medical Center, Princeton. She has been a principal and sub-principal investigator for numerous clinical trials. Dr. Vance is the clinical coordinator of medical oncology and hematology for the Brookwood Baptist Medical Center Internal Medicine Residency Program. Dr. Vance recognizes that a traditional medical practice model fits the needs of many patients. Other patients, however, are seeking something different from their medical encounters. As the founder of Cancer Solutions, LLC, Dr. Vance helps cancer patients to live better, fuller lives through actionable ideas and real-world strategies. With her Amazon best-selling book, Journey, a simple roadmap for newly diagnosed cancer patients and their families. Dr. Vance helps patients and their families navigate a new cancer diagnosis. Dr. Vance is a member of Alpha Kappa Alpha Sorority Incorporated, and Dr. Vance and her husband, Al, have 2 children, Ryan and Oliver. Olivia, sorry.
Dr. Vance, for joining us in this discussion about male breast cancer and what you need to know about it. So, Dr. Vance, our first question is, how rare is male breast cancer?
Well, Stacey, thank you so much for having me and allowing me to talk about this very important topic. So male breast cancer is actually not something that you hear about a lot. And the main reason for that is that it is exceedingly rare. So male breast cancer is only about 1% of all breast cancers that we see, and it's probably only about 1% of breast cancers worldwide. And so when you consider how much more common breast cancer is among women, male breast cancer obviously is just not talked about quite as much for that reason.
So what are some early warning signs of male breast cancer? Like, how would a man know that this is what he's experiencing or what he could be experiencing?
Yeah, that's a really great question. And so for men who may need to be concerned about something that they are seeing or feeling with their breasts, one of the signs can be actually a mass or a lump. And for men, most commonly, the breast mass is going to occur right under the nipple complex. And so that is very different for women, where you will hear that more commonly a mass is going to be in the upper outer part of the breast. For men, more often what they'll experience is actually a painless lump in the breast. Very often it will be described as something that is firm. So if there's a lesion or a mass there that is hard, that's something that you want to get your doctor to check out. Usually, if this mass is going to occur, it is going to be on one side. And so that's important because there's something called gynecomastia, which is just a benign or non-cancerous enlargement of the male breast. One of the differences with that is that when it occurs, it is usually seen in both of the breasts and not just one. And so in young men who are going through puberty, they may have enlargement of both of their breasts. It's a non-cancerous problem. But on the other end of that spectrum, when you're talking about male breast cancer, it may just affect one breast. The other thing that a man might notice is an ulceration. So that is an area of the breast where there is actually an opening or a sore. Sometimes the nipple can do what we call retract, and that is where the nipple actually turns inward on itself. And so for some men, that may be a normal finding for them. But if all of a sudden you notice that the nipple used to point out and now it is actually turned in, that can be a sign that there is actually a problem. And then one of the last things that a man may notice is actually a nipple discharge. You know, for anyone to have a nipple discharge, that's something that you should talk to your doctor about. There can be normal or what we call physiologic breast nipple discharges. But if you've got something that is bloody, that is green in color, even if it's clear or white, it is something that you should mention to your physician as something that should be worked up. But those are some of the common signs that a man might see.
So if a man sees any of those common signs, how would they go about getting screened for?
Yeah, so the first thing that he should do is to actually make an appointment with his primary care physician. And, you know, this has actually happened in my practice before. If you were to talk to any number of primary care physicians or medical oncologists or you know, any doctor who does primary care, what they'll tell you is that the majority of men will sort of write this off. They'll decide, oh, it's probably nothing because there is obviously a misconception that men can't get breast cancer. And so I think this conversation is so important because even if you talk to your doctor and it turns out that it's nothing, it is much better to seek medical attention to have it evaluated as opposed to watching it grow. And especially if it's watching it grow where it becomes an advanced problem that's no longer curable. Although males have much less breast tissue than women do, it is still possible to do mammography. And so I know that sometimes it's a bit of a misconception that because the male breast is not very large, that it's not possible to do a mammogram. But in fact, that is the modality of choice when you are examining a man who has an abnormal breast finding. There are other tests that you can do, for example, ultrasound, but still the gold standard test is going to be a mammogram.
Okay. So does heredity play a role in male breast cancer?
Yeah, absolutely it can. And, you know, these days what we have discovered is that when we are talking about almost any malignancy, and especially male breast cancer, we are going to want to take a very close look at the family history. And so what's going to be important, first degree family members, so we're talking parents, so both mom and dad, siblings. This includes your sisters and your brothers, because obviously here we are talking about male breast cancer. And so often when we talk about heredity with breast cancer, people will come to me and they only have a history for the mother side of the family, for example. And so I think it is extremely important to make sure that we include both the maternal and the paternal side of the family, because we have to remember that half of that genetic pool is going to flow down from the father side of the family. We know that for men with breast cancer, if you were to look at their family history, very often you may find that there are other family members with breast cancer. It is actually quite interesting for men who have breast cancer, their sisters have a much higher risk of breast cancer than when it is the other way around. So, for example, if there is a sister with breast cancer, the brother's risk does go up, but not nearly as high as it does for the brother with breast cancer who has a sister. We also have heard a lot about the BRCA1 and BRCA2 mutation. I think Angelina Jolie helped to make that very popular among the lay public. And so what's interesting is that patients who have a BRCA2 mutation, their risk, male patients that is, have a much higher risk of developing breast cancer than men who do not have a BRCA2 mutation. Still, the BRCA1 mutation also confers a higher risk. And there is another syndrome, an interesting syndrome called Klinefelter syndrome. And most people probably have never heard of Klinefelters, but we all have two sex chromosomes. So for females, you have two X's, and for males, you have an X and a Y. But with Klinefelter syndrome, you still have a male phenotype, so someone who looks like a male, but they get an extra X chromosome. And so we know that the patient, the male with Klinefelter syndrome, his risk of having breast cancer actually goes up probably 50 times higher than the average risk. And so there are always some very important questions to ask about heredity when we find a male with breast cancer. I actually have a male in my practice whose brother also had breast cancer. Both of them presented with fairly late stage disease, primarily for the reasons that I talked to you about, and that is they discovered a mass in the breast, and as is so common, it was something that was kind of pushed aside because just thinking about male breast cancer was not something that was high on their priority list.
So, with all that said, is there any type of routine screening for male breast cancer? And if no, why not?
So there is not routine screening for male breast cancer. And the primary reason for that is what we discussed at the very beginning, which is this is a really rare problem. And so when you're talking about screening tests, you are looking for disease processes that occur commonly in the population. And so if you compare male breast cancer to female breast cancer, in any given year, you're going to have about 250,000 women in this country diagnosed with breast cancer. And so with that many women, obviously screening is extremely important. You want to find those cases early. With men, however, you're probably on any given year going to have about 2,500 cases of male breast cancer. So to think about screening an entire population to find that 2,500 cases, that actually would not be feasible. However, when you are thinking about the male anatomy, and because there is so little breast tissue, what I instruct every male to do, just like I instruct every female to do, is to know when there is something different. And so if there is something different in your breast, even if you are absolutely certain that it's nothing, that's something for you to talk to your physician or your primary care provider about. So no, we don't do an annual screening mammogram for men. And I should say men who are of average risk. There are certain males in our population who we know may be at increased risk. So for example, the male who has a known history of Klinefelter syndrome, or a male who has a BRCA2 mutation. I would definitely have some rigorous discussions with the primary care doctor about how to best manage those cases, because they're going to be a little bit different. But if you take the average male who has no family history, who has no other risk factors for developing male breast cancer, then it is strictly about knowing your body and knowing when something's different.
Okay.
Yeah.
So you were talking about the risk factors. How would one know? How would one become aware of what those risk factors are if they have a high risk factor for?
Yeah, so whenever I'm talking to people about any sort of cancer or malignancy, I always like to empower people. And that empowerment comes from knowing that there actually are some modifiable risk factors. There are things that we can do for ourselves to lower our risk of particular types of cancer. Male breast cancer is actually one of those. And so there are non-modifiable risk factors of things that we talked about. You can't change your heredity or who you were born with, as much as some of us might like to change who we're born to. We've been dealt that hand, and that's just what it is. But in terms of those modifiable risk factors, we know that making healthy lifestyle choices, so getting exercise, and I usually tell my patients, you got to be getting in that 150 minutes a week. And so what does that lifestyle change do for you? It makes sure that you are keeping your weight under good control. So we know that men who have a BMI of less than 30 are going to have a lower risk of developing not just male breast cancer, but so many other problems that we associate with being obese or overweight. Limiting alcohol use is one of the things that may lower the risk of having male breast cancer. Not smoking is going to lower the risk, but look, I'm going to tell every patient and everybody who will listen that not smoking is not just about cancer risk. It is about all of those other comorbid states that we see, especially in the Black community. So from cerebrovascular disease, heart disease, and cancer risk, we're going to see all of those things go down drastically by not smoking. And then I think it's also important to mention other things that we know can increase the risk of male breast cancer. Interestingly, marijuana use has been shown to increase the risk of male breast cancer. And we also know that, anabolic steroids. So, when you think about the guy who's doing all of the weightlifting and using anabolic steroids to increase muscle mass, one of the things that's also happening is that that person who's using anabolic steroids is altering their estrogen state. And a high estrogen state is a risk factor for developing male breast cancer. It's probably one of the reasons that we also don't see it as commonly in men, because their estrogen states tend to be quite low.
Okay, so you've given us some really good facts for us too, and hopefully for all the guys that are here and all the ladies that have men in their life, their loved ones, to share this information with them. Is there any last thing you'd like to share with us about male breast cancer that would be important, something that I may not have asked that you think we really need to know?
Yeah, I think we covered a lot of the high points. I think just to re-emphasize the importance of, if you find something, say something to your primary care provider. I think one of the things that I've noticed with many of my male breast cancer patients, and I say many, nobody's going to have a tremendous number of male breast cancer patients in their practice because it is so rare, but there is almost a hesitancy to talk to the primary care provider or the medical oncologist, because there's a thought that this is a female's disease. And let me put an end to that taboo right now and say that if you got breast tissue, then you can have breast cancer. And so that is what is so important to emphasize. If you find something that's wrong, make sure you're talking to your primary care physician. Don't delay making that appointment, even if you get there just to find out that it is a non-cancerous issue. Many times what we end up doing is reassuring patients that it may be related to a medication that they're taking, which is actually fairly common. Some of the medications that I give to treat cancer can actually cause non-cancerous enlargement of the male breast, but it is always best for you not to be the one to decide that it's a non-cancerous problem. Don't let Dr. Google decide that it's a non-cancerous problem.
Yeah.
Please talk to a medical provider about it.
Well, we want to thank you so much for talking to us about this very important subject. We just think that everybody needs to know about male breast cancer, because we want to make sure that if people are out there and they're having symptoms and they don't realize it, that they take it seriously and they get help. We hope that you were able to join us later in this program to answer questions that may come from the audience. And again, I want to say thank you so much, Dr. Vance. It has been certainly a pleasure, and we really appreciate what you're doing out here. And thank you for sharing, talking to us with this very important subject.
Dr. Jones, thank you so much for having me.
You're welcome.
Wow. So much important information was shared by Dr. Vance, including tips on how men can identify breast cancer for themselves and the different types of mutations. We really appreciate Dr. Vance for taking the time to share her knowledge with us for the betterment of all of the men who are tuned in today and for all of us who have male loved ones in our lives. We will now hear from a surgical oncologist named Dr. Oluwadamilola, also known as Lola Finju. Dr. Finju is the inaugural Helen O. Dickens Presidential Associate Professor in the Perelman School of Medicine at the University of Pennsylvania and the Chief of Breast Surgery for the University of Pennsylvania Health System. She is also Surgical Director of the Rena Rowan Breast Cancer Center in the Abramson Cancer Center, and an Innovation Faculty Member at the Penn Center for Cancer Care Innovation, also known as PC3I. She is an academic breast surgical oncologist whose research focuses on health disparities, aggressive breast cancer variants, and improving value in oncology, particularly through the collection and application of patient-reported outcomes, also known as PROs. She received her undergraduate degree in history and science and a master's in comparative literature from Howard. She received her medical degree and a master's of population health sciences from Washington University in St. Louis, where she also completed her residency in general surgery. She completed fellowship training in breast surgical oncology at the University of Texas Anderson Cancer Center. In 2019, she was recognized by the National Academy of Medicine as an emerging leader and health and medicine scholar. Her research is supported by funding from the National Institutes of Health, and she has published in a variety of journals, including Annals of Surgery, Cancer, and JAMA. We will now welcome Dr. Finju.
Well, we want to thank Dr. Finju for joining us in this continued conversation about male breast cancer. So, Dr. Finju, what are some options for treating male breast cancer?
So male breast cancer can be treated in just the same way as female breast cancer, with the caveat that male breast cancer is often diagnosed at a later stage, so may require more extensive surgical treatment, as well as the addition of chemotherapy, endocrine therapy, that is medications to treat the cancer, as well as radiation. So stage for stage, and with regards to subtype, whether it's triple negative or fed by hormones, the treatments are the same for men and women. The only difference really is what stage it's being diagnosed at. For men, it tends to be more advanced. They typically need more treatments.
So what should someone expect when having surgery for male breast cancer?
So the kind of surgery a person gets depends on the size of the tumor relative to his breast size, as well as whether or not any of the lymph nodes underneath his arm, that is the axillary lymph nodes, are involved. So if a man is a bigger individual and has a relatively small tumor, he is also eligible for a lumpectomy, or breast conserving surgery, which is where we remove just the area of concern. If it's not something that can be felt, if it's not palpable, we have a wire or a seed placed into it that we can then use to localize the tumor and excise just the area of the cancer. And then subsequently, we administer radiation to sterilize the field and decrease the risk of local recurrence. If a person has a larger tumor relative to his breast size, and this tends to be more common in men because it's more likely to be diagnosed at a slightly later stage, then they can undergo mastectomy in the same way that a woman would. With regards to their lymph nodes, if they don't have any evidence of lymph nodes involved when they first present and they're going to surgery, then they would also get what's called a sentinel lymph node biopsy, which is where we sample the 1 to 5 lymph nodes that are guarding the axilla or guarding the breast. That is the lymph nodes that if cancer were to travel outside the breast, they would be the first stop. So we now know that if those lymph nodes are negative, that is, they don't have cancer, we don't necessarily need to go and take all the other lymph nodes underneath the arm. In the past, that was standard of care, but now we know we can be selective and just sample a few of them. So again, if a man doesn't have any evidence of cancer when he first presents, he would also just get a sentinel lymph node biopsy, that is removal of a few lymph nodes to confirm there's no cancer in them. If he does have cancer in those lymph nodes, or if prior to surgery it becomes clear he has cancer in his lymph nodes, then he would get what's called an axillary lymph node dissection.
Wow. Okay. So, I mean, you really said a lot there about the treatment in terms of surgery. What is the expected recovery time? What does that look like?
So recovery is different for everyone. I think that, there are some people who a couple days after surgery, they feel much like themselves. And there are others for whom it takes a longer period of time to really get back to normal. What I found for patients is the thing that actually ends up being the most life-limiting is having a drain in place. So if an individual undergoes a mastectomy or a lymph node dissection, he or she will have at least 1, possibly 2 drains that are coming out of their chest wall. There are tubes that are typically connected to a little clear plastic bulb. And those tubes drain fluid from where the breast and where the lymph node tissue used to be, because the body likes to fill spaces where something's been removed with fluid. It's kind of our body's way of filling that space. And so the way we keep that fluid from becoming a permanent fluid collection is to have it being drained out of these tubes. And then that amount gradually decreases over time as your body gets used to the new normal with the absence of the breast and the absence of some lymph nodes. So for a lot of people, the drains are not so much painful, but they're quite annoying. They obviously extend quite a ways out from the body, and they need to be often pinned to clothing or kept in little garments that actually keep the drains close to the body. So as long as someone has those drains and their pain use tends to be a little bit higher, and they might be more likely to also need narcotics, which means they should not be driving. That being said, we hope that most people can get through breast surgery without needing narcotics. So they should be fine with Tylenol, ibuprofen, ideally getting good pain control during surgery that then gets them through the acute period of the most pain. But I would say for most people, we would recommend that you take at least 2 weeks off from any kind of work, ideally about 4 to 6 weeks off after surgery, specifically because we want to make sure the drain doesn't get dislodged, that your pain is well controlled without narcotics. And also we want to make sure that you aren't lifting anything more than you should, which is more than about 5 or 10 pounds. And we typically want that for 4 to 6 weeks. And finally, the only other restriction is that we don't want people to soak in a tub or go swimming because we want our incisions to have time to heal. So between all of those restrictions, typically we encourage people to take anywhere from 2 to 4 weeks off, at least.
Okay, so I have one more quick question. It goes back to something you said earlier about having surgery and then possibly having radiation. Is there some lag time between healing from the surgery and then going on to have radiation?
That's a great question. So radiation is not required for everyone. We typically do give it to everyone who has a lumpectomy, because lumpectomy with preservation of the breast, we know that we need radiation to have similar long-term outcomes to having mastectomy. With mastectomy, people only need radiation if they have involvement of their lymph nodes or if their skin or chest wall is involved by tumor. Typically, those are the indications for getting radiation after mastectomy. So with radiation, we need to give the body a chance to heal after surgery. So typically people wait about 4 to 6 weeks after surgery before they begin radiation. And that allows for your body, again, your incision to heal, because radiation is the delivery of high dose energy that can affect the skin and potentially interfere with wound healing if it's not been completed.
Okay. Thank you for that. So, another question related to the surgery. Does this type of surgery require any reconstruction, or do people just have to choose whether they want to have some type of reconstruction?
That's a great question. There are many men who also have concerns about the appearance of their chest after mastectomy. Reconstruction isn't typically done, but there's no reason why it could not be. Again, we're increasingly offering men who have small tumors the option for breast conserving surgery, in which case they are able to keep their breasts, and therefore under clothes, they don't look that different from how they would have looked prior to surgery. So reconstruction is not common, but it is potentially an option for men for whom that would be very important. And they can discuss that with their surgeon and with their plastic surgeon.
Okay. So are there any shocking truths that you have learned when it comes to breast cancer, and specifically breast cancer for men?
So breast cancer for men is rare, but having worked in a veterans hospital in the Veterans Administration, I have seen and treated it a number of times. And the most important thing is that men need to know their bodies and know when something has changed. The good news is the vast majority of the time, if a man notices he has lumps or masses underneath his breasts, almost always that is going to be gynecomastia, which is a benign tumor that is very common in men, more common in people who are obese as well. That being said, if a mass is persistent, if it's painful, and if it's only on one side in particular, people should go and get it checked out, even if just to be reassured that it's gynecomastia. The tragedy of male breast cancer is that, as I mentioned before, it's often diagnosed at a late stage, by which time it's already invaded the chest wall or the skin or gone to lymph nodes or even beyond that. So an opportunity to diagnose early is an opportunity to cure with less treatment and less morbidity and side effects from treatment. So what I would encourage men to do is, 1, know your body. 2, don't ignore new findings in your breast. Again, you want the peace of mind of knowing it's not cancer, because most of the time it won't be cancer. So why not go ahead and find out? The third thing I would say is, if for a man who has a strong family history of women and any men in the family who have breast cancer, it may be worth it for him to go ahead and find out if any of his family members have had genetic testing, and for him to potentially pursue genetic testing himself. Any man diagnosed with breast cancer is recommended to have genetic testing because it's associated with some of the genes that predispose women to breast cancer, as well as ovarian cancer as well. So any man who has breast cancer needs to have genetic testing. Not infrequently, what will happen is that the gene has been passed down through the family, but there may have been several generations of men and no women. And so people don't see the breast cancer necessarily manifesting in those individuals, but it can. So as I mentioned, know your body, get things checked out if something changes. If you have a strong family history, and in particular know anyone who has male breast cancer in your family, consider genetic testing yourself. And if you as a man are diagnosed with breast cancer, it's important for you to get genetic testing and to encourage your other family members to get that as well.
Wow, thank you. So one last question. What else should we know that we have not asked?
I think the thing to know about male breast cancer is there's absolutely nothing to be ashamed of in having male breast cancer. All of us have breasts. And the only difference between men and women is that over the course of our reproductive lives, women get higher doses of estrogen and progesterone, the 2 main female hormones, which cause our breasts to become the milk-producing organs that they are during pregnancy and after childbirth. But breasts are organs that all of us have. And in the same way, not all women get breast cancer, the vast majority of men don't get breast cancer. But there is certainly no shame to be associated with getting it if you do. It is treatable if caught early. And we increasingly have very, very good both surgeries as well as systemic therapies, that is endocrine therapy, chemotherapy, targeted therapy, and immunotherapy that can make breast cancer be eradicated and hopefully just be a blip in someone's otherwise long life. So I would encourage men to know their family history, take care of their body, seek out healthcare when they feel like something is wrong. In many families, women are the main healthcare decision makers. So even if a man is reluctant to pursue care, hopefully he can confide in a woman who loves him, who will encourage him to do so.
Well, we want to thank you so much for sharing this very important information to us. And we look forward to you joining us for questions and answers from our audience.
Thank you so much for having me.
You're welcome.
Thank you again, Dr. Fayonju, for the information you provided around what the surgical treatment and recovery would look like for a male who is experiencing breast cancer. Our hope is that those who are watching have gained some great takeaways from both you and Dr. Vance, and I am really looking forward to seeing the questions that we received during the question and answer portion. We will now hear from the All of Us Black Greek Letter Consortium's very own Sir Jennifer Jones, who will share some of her family history with us around breast cancer.
Thank you so much for joining us, Jennifer Jones, or JJ as we all know you. Since you've had the opportunity to hear from both Dr. Vance and Dr. Fayonju, and you also saw the male breast cancer survivor's journey earlier in the program, I know lots of things might be flowing through your mind, lots of memories. And we were hoping that you could share a little bit about your story, but also talk about your family's journey with breast cancer.
Yes, actually, I was putting in the chat because a lot of the memories resurfaced, as particularly when Dr. Vance was talking about some of the signs for males with breast cancer, and they said usually they have a lump below their nipple, and I had the exact same thing, and so I wasn't even common based on what she was saying that women would have. So that was very interesting, and all the different things that the doctor talked about, the surgeon talked about with the different treatments and things. I not only had radiation, but I also had chemo as well. So I was diagnosed with breast cancer in 2013. It was stage 3 at the time that that I found my lump. Actually, well, I say that my dog saved my life because I rolled over to put a blanket over on him because he liked to sleep near my bed, and I rolled over the lump, and like it was very defined. I could feel it. I woke up. It was like 3 o'clock in the morning, and I woke up my husband and told him that I had a lump in my breast, and immediately I began to the next day, because that was 3 o'clock. It was on a Friday. I began to call my general practitioner because I knew the process. I don't know why I knew the process, but I knew the process. If you need to get a referral and all of this, it was a lot. But within a few days, I was. She actually did a sonogram, a biopsy and a sonogram. The sonogram was first, and she did see something, and she told me then that it was probably cancer. And then within another couple of days, she did the biopsy, and it was cancer. And it was. I won't say I was shocked. I was shocked in a sense, but I was ready to get it over with and do whatever I had to do. And I began to do all this research and try to figure out exactly what I had. I had the triple negative, which is common in Black women, and the mortality rate is not great. But I didn't think about all that at the time. And then at one point, my doctor told me to stop Googling it. Just stop. And I did. And so my regime was to have 8 rounds of chemotherapy and then 34 bouts of radiation. I had the 7 rounds of chemo, and after the 7th round, I developed neuropathy in my hands and my fingers. And it was happening all along, but it began to get worse and worse. And so they had to stop the chemo because they said that if I continued it, then it would probably I would have some permanent numbness in my feet and in my hands, and to the point where I wouldn't be able to utilize them. So they stopped that, and then after that, I had the 34 rounds of radiation, and I would go in every morning. It was every day, Monday through Friday, unless it was a holiday, and I would get my radiation. They would target 2 different spots, 2 different areas: the area underneath my breast and then the area on top of my breast. I had 7 lymph nodes removed. After the first surgery, they found cancer in one of the lymph nodes that was further back in my breast, which was alarming. So I had to go back in the next week to have a surgery again for them to widen the margin to see how far back, to take out more lymph nodes to see if they were cancerous. And they did that, and it wasn't. Which in my mind, I'm not a doctor. And like Dr. Vance was saying, don't diagnose yourself. I didn't. I just thought about it. It's because the lymph node was not one closer up that had the cancer. I always had it in the back of my mind. what if that thing back there, there was cancer still growing back there? Because I had a lumpectomy the first time. So they didn't remove the breast. I was all prepared for that. But my surgeon at the time said that she didn't think that we needed to be that invasive. So I went through treatments, was cancer free, went 4.5 years because they tell us within the 5th year, if you're going to reoccur, it'll reoccur within that 5th year. And so I was 4 years and 5 months in getting my checkup, my 6 months checkup, and they found another abnormality in the same breast. And so I had to go back to the doctor, have another biopsy, and it was the exact same breast along the incision line of where they did the lumpectomy. And so at the time, of course, I asked the question of my doctor that was this from the first time that you just missed something, or was it a new episode is what they call it? And she said, we can't tell, but we could spend a whole lot of money trying to figure it out. But at that moment, it wasn't important because I had cancer again. And so this time I could not have radiation. So we did a bilateral mastectomy where they removed both of the breast. And when the doctor or the surgeon was talking about the tubes, I had 6 of them. Very annoying, very, very annoying, trying to sleep with that. And every 20 minutes or so, we had to drain them and measure them. So my husband had to drain them and measure them to make sure that the fluid was decreasing, because if not, that could be a problem. So then, and I was on the table for 8 hours in the surgery because not only did they remove the breast, but they also started the reconstruction as well. They did that at the same time. So I had a plastic surgeon come in after the surgeon to start that. So I am like, let's see, how many years? 3 years in now, because I was re-diagnosed in 2017 and started my treatments in 2018 because I was diagnosed in December and I started my treatments in January. So I am 3 years in. Again, I'm waiting for that 5th year so I can ring that bell to say, hey, it's done and over with. So I look forward to that.
Wow, thank you. That is just amazing. So tell me, is there a history of cancer in your family?
There is a history, but okay, so my mother died of cancer, my father died of cancer, my first husband died of cancer, my brother actually was diagnosed 2 months prior to me. The second time he was diagnosed with liver cancer, and he succumbed to it in February, because I started my treatments in January and he succumbed in February. My mother-in-law died of cancer, the exact same cancer that my first husband had. He had lymphoma. And so, of course, when the cancer reoccurred, my doctor had me, my oncologist had us do a genealogical test to see if it was hereditary. And so I had that done and went back to get the results, and it is not hereditary. Wow. So yeah, it was not hereditary. So what we did find out is just because of where I grew up and lived, that it was environmental. And as we opened this program, we talked about the All of Us research program, and some of the things that they look for as we're dealing in precision medicine is the environment that you come from, your background, your family background, and all of that. And it was environmental because of the chemical plants that I grew up in, and that everybody from that area, my first husband was from that area as well. And they all died of cancer. So even during that period of time when I was diagnosed the first time, my children were very young when their dad died, and their frame of reference to cancer was death. And so it was very, very, very hard for them, for me to even talk about that around them. My son didn't want to see my bald head. I had to wear caps, but I was very cognizant of that. But we talked about it, particularly after I began to work with this program, because the more I learned from this program, the more I could provide information that I could provide my kids. And we were being proactive in trying to figure out, what's going on with our family, and to know that it was chemical. And actually, I will say this too, after doing that genealogical test, they said I wasn't even susceptible to have cancer. So that was like, whoa. So yeah, so that, just to know that and to learn that, I kind of breathe a sigh of relief. But and knowing that about my body and my makeup, and so of course I will have my daughter tested early, just in case, you know, even though it's not, because I just had a young, my 32-year-old niece was just diagnosed with breast cancer on my husband's side. So just out the blue, and she grew up in the same area. And so one of the things that we are looking into as a family, because in the area that I was raised in, that they have a that was kind of like a class action suit for one of the chemical plants, to where any sibling or spouses that was exposed to their loved one who came home with asbestos, there was asbestos in the plant, then they were actually getting cash settlements because of that. And so I even looked into it about breast cancer. And so that was one of the cancers that they did not include in this. So, but we're still fighting it. We're still fighting it.
That's wow. That's all I have is wow. JJ, I really want to thank you for sharing the details of your personal journey and your family's health challenges. And you just make us know how important it is for us to do routine screening and for us to really pay attention to our bodies. And I'm sure there are some viewers who have been in similar positions as you. And this is why we are hoping that this program will bring the right amount of awareness to encourage everyone to stay on top of their health.
Yes.
We will now open the floor for questions. We have Doctors Vance and Fyanju live with us, and JJ, you as well, so that we can talk more about breast cancer. And so we do have a question. The first question is, what factors does race and age play in men and breast cancer, if any?
Hey, good evening. So I'm happy to jump in on that. And so, interestingly, one of the things that we know is that African American men or Black men actually seem to have a higher rate of male breast cancer than their white male counterparts. And you know, there's probably not just one thing that plays into that. There are probably multiple things, just like Jennifer, who just told her story so beautifully, has talked about the effects of environment. We know that there are so many other things that play into it. So there's not just one thing that is going to increase that risk. We also know that for all patients, your risk of breast cancer increases as you get older. It's one of those non-modifiable risk factors that we talked about. And so for men, the peak incidence for breast cancer seems to be around the ages of 60 to 70. So that's 7th to 8th decade of life. That is not to say that a man can't get breast cancer earlier. Certainly they can. But we know that that seems to be the time that they are at the highest risk. And so that's a great question, and I hope that that helped to clarify your question.
I will also add that many of the factors that contribute to later stage diagnosis amongst Black women, we will also see amongst Black men. And so just increased difficulty with access to primary care. So having someone who is doing regular exams for you and able to connect you quickly with appropriate imaging to follow up on the abnormal finding you might notice. We know that Black people are less likely to be offered and to take advantage of genetic testing. And given that, you know, a significant proportion of male breast cancer is associated with a gene that we can actually detect, people who are connected to genetic testing and risk assessment prior to the diagnosis of breast cancer, that's a win for us. You know, we love if we can find those people, but we're less likely to find those individuals amongst Blacks because we aren't necessarily offered genetic testing. People aren't thinking to look out for these things for us. Another thing I will say is then the other situation is, of course, systemic bias, that when you come to your primary care physician, are you listened to? Do people take your condition seriously? And that is something that is, we all know has always been a problem, but has really come to light more again to the lay public with the COVID-19 pandemic. The number of Black people who went to their primary care physicians, reporting symptoms that seemed very consistent with COVID early on in the pandemic, yet they were dismissed, they were disregarded, they were not tested, they were not treated, they were turned away from hospitals, they were discharged early. So that is all to say is that we are our own best advocates for ourselves. And if you notice something, do something, because you may not have people in the healthcare system who are frankly fighting on your side the way they should.
Thank you for that. I do have a couple of other questions. One, you talked about genetic testing. So how would one go about getting genetic testing? So what would you do to be able to do that?
Yeah, so it's actually not very hard at all. And Dr. Lola, thank you so much for your comments about access. Interestingly, there was just a study that I looked at this past week that showed that patients who had all of the indications for genetic testing, if you were from a minority population, you were much less likely to be offered genetic testing. And I think that for what it's worth, sometimes we have to recognize that it's the squeaky wheel that's going to get greased. And so what I mean by that is we have to go into a physician's office and we have to be informed. We have to advocate for ourselves. And getting genetic testing, believe it or not, is just a matter of getting a swab in your cheek is one way to do it, or the other way is a simple blood test. These tests are actually covered by insurance companies. They are widely available, so you don't have to go to a specialized center to get it done. Most cancer centers will offer this testing, and it is very, very easy. The other thing that is extremely important, and one of the reasons why minorities may not get testing as often, is that if you are uninsured or underinsured, you may have some difficulties accessing these tests. But what I want people to know, and what I want for you to demand, is that your provider look for resources so that you can get that testing done, because some of these companies will actually provide testing free of charge, or they will write off the testing if you are uninsured or underinsured, but we have to know to ask for it. And so if we are that patient who has triple negative breast cancer, like JJ, who has just talked to us, one of the things that we know is that if you're under the age of 60 with triple negative breast cancer, even if you have no family history of breast cancer, then genetic testing is indicated. So you don't have to go in saying that your mother or your sister or an aunt or your cousins also had breast cancer. That triple negative diagnosis gets you testing for hereditary forms of breast cancer. If I have a male breast cancer patient, just like Dr. Lola has talked about, those are my patients who I'm saying you have to get genetic testing. Importantly, though, I think that there is also a bit of distrust in our community. I have also talked to patients before and I've said, we need to do this testing. And sometimes there is concern that, what are you doing with my DNA, or what's happening with these results? Please understand that these results are meant to offer you state-of-the-art care. So there's no conspiracies. Nobody is going to hold this information against you. Quite frankly, it is always going to be in your best interest to get the most information that you can about yourself and about your diagnosis. So please, if a provider says to you, let's do this genetic testing, then be willing to proceed with that.
And I will follow up on all the excellent points by Dr. Vaughn to say that actually I think the NCCN, or the National Comprehensive Cancer Network, may have just now said that actually anyone with triple negative breast cancer, regardless of age, can get genetic testing. So there's one more barrier removed. And the thing about it is, unfortunately, in the United States, insurance is a beast we should not have to deal with, but we do have to deal with. And even if it turns out for some reason that you don't strictly fit the criteria for genetic testing, you should be eligible for genetic counseling. And then they can give you an informed decision. You can make an informed decision about whether you want to pay out of pocket for your genetic testing or not. And even if you do, it's often costs that can be covered and for which there are funds available, as Dr. Vaughn just mentioned. So do not let insurance or costs be a barrier to getting the knowledge that you deserve. And I think the other thing that we really need to I want to emphasize again is we have to be honest with each other within our families. It's okay to talk candidly about the cancer you have and what part of your body it affects. Because not only is having a family history of breast cancer associated with breast cancer, having a family history of ovarian cancer can be associated with the risk of breast cancer too. And a lot of families, they'll just say, oh, grandma had a woman's cancer. Well, ovarian cancer, cervical cancer, endometrial cancer are completely different origins with different risk factors and different associations with other types of predispositions or genes. So really important for us to love ourselves enough to know ourselves, to talk to each other. There's no shame in talking about these things and knowing about them so we can really help each other.
Okay, thank you so much for that, Dr. Fayinju. So here's another question. Are there any foods or habits other than smoking that have been linked to breast cancer?
Well, there are factors that I'll just say briefly, things that we know can improve the risk of breast cancer. So one is we encourage breastfeeding. There is some evidence that breastfeeding decreases the risk of breast cancer. And sadly, rates of breastfeeding are really not as high in the Black community as they ideally would be. Now, I'm going to tell you, fed is best. And there are people who find themselves struggling to breastfeed, which is challenging because frankly, more and more of us have not seen our own mothers breastfeed. So breastfeeding is natural, but it's not intuitive. It is hard. Anyone who's breastfed knows that it is a journey for mother and baby. But it is a journey worth making, and it's good for baby's health and for your own health. So I've heard women who have said, I can afford formula, and they almost are insulted when people say, well, you should breastfeed. And it's like, no, breastfeeding is like the gift that keeps on giving. It's free and it helps your health and your baby's health. So breastfeeding is great and something I really want to encourage all of us to do more of and to encourage the young women in our lives to embrace. It's wonderful. I breastfed both my kids, even as a busy surgery resident, and I still miss it. The other thing I will say, we do know that excessive alcohol can be associated with a risk of breast cancer. So if you are struggling with alcohol excessive use, that's something to seek help for many reasons, but decreasing your risk not only of breast cancer, but also frankly of liver cancer is an important reason to do that. We know that probably all of us need to, move more and eat less, especially after the COVID-19 pandemic. So whatever you can do to stay healthy and minimize obesity, though obesity has kind of a complex relationship with breast cancer. There's some evidence that it might be actually slightly protective in premenopausal women and slightly more disadvantageous women who are after menopause. But that aside, the healthier you can be, the better health you can be. And overall, those are all good things to encourage.
Yeah. And so one other thing that I think is very important for our community to hear about, and Dr. Fayinju, I breastfed my 2 children and I called it liquid gold. It was, yes, it's hard work. Oh my goodness, it's worth it. You just gave me some flashbacks there. That is such a good thing for us to talk about in our community, because I do think that there is a bit of a taboo associated with it, and we've got to get past that point. But the other point that I was going to make was the sister study that actually came out in 2019. And this is important as we go through our natural hair revolution. So it was an observational study, 46,000 women. And these were all women who had sisters who had breast cancer. And so basically they sent these women questionnaires and followed them to see which of these women went on to develop breast cancer. And one of the interesting findings in this study was that women who used permanent hair dye and women who used straighteners in their hair had a higher risk of breast cancer. Now, this study is a little tricky because obviously these women are already at higher risk because their sisters had breast cancer. But I think it begged the question, if there's something else that you can do to lower your risk of breast cancer, maybe this is one of those things. And so I've had lots of patients who ask me about it because they looked at me and they go, well, you dye your hair. And I was like, well, yeah, maybe. A girl never tells. However, one of the things that came out was that the frequency of hair dye seemed to be important and the type seemed to be important. So what they sort of teased out was that for women who were dyeing their hair more often than 5 or 6 weeks, who were using permanent products, their risk seemed to be higher. And then hair straighteners. So our relaxers seemed perhaps to be contributing to the risk of breast cancer. And so the bottom line for this study for me was that, you know what, if you're somebody who's at high risk, keep this in mind. Obviously, it's not a retrospective, it's not a randomized control trial where we said, we've got these women who match up with these women, we're doing this here and not doing this here. It's an observational study. So it's not the highest quality study, but it was actually one of the very first studies that gave us a true hint of the possible effects of some of these chemicals. And so it's one of those things that I talk to Black women about, especially if it's somebody who is already at high risk. I say, think about it. Maybe it's something that you can do different for yourself. It's interesting that the person who asked that question put in the part about smoking, because everybody always says, well, except for smoking, because I don't want to talk about smoking. And so smoking is a really big deal in the oncology world, because even though this is Breast Cancer Awareness Month, and we know that breast cancer is really high up on the list when we're talking about mortality and breast cancer incidence for women, and we're talking about men tonight, but we cannot ignore the fact that lung cancer is the #1 killer of men and women in this country. And so smoking, we're always going to say, hey guys, don't pick up the habit, don't start it. And it's not just for breast cancer, it's for all of those other cancers that we have to deal with on a daily basis. So it's all about being good to yourself.
The other thing about smoking is that, frankly, can compromise the treatments you do get, for treatment. So as a surgeon, we know that if you smoke, your risk of problems with wound healing, your challenges with reconstruction are just so much greater. Your risk of getting lymphedema or arm swelling after breast surgery is so much higher. So, a lot of my patients, when I first meet them and I find out that they smoke, that's one of the first referrals I make is to tobacco cessation. And I don't minimize how hard it is to quit smoking. Smoking, people have said, is the second hardest addiction to quit after heroin. So, it's really addictive. And again, think about it. People are afraid of putting vaccines in their body. These cigarettes were engineered to be consumed by us to our detriment. So the idea, when I see people complaining about vaccines and worrying about vaccines, but smoking, I don't even know what to say. It just breaks my heart because, and I'm sure, Dr. Jones, Dr. Vance are with me here, where, seeing the devastation that COVID-19 has had on our community is really, it's a lot. It's a lot. And I'm going to be honest with you, your physicians, we're burning out. We're exhausted because we're not just bearing the load of being doctors, we're bearing the load of being Black people in a pandemic that's disproportionately killing us. And so to see the things that we can do to make our lives better as a community, as individuals, and people not taking advantage of them is a lot. It's a lot to see. So anyway, getting back to the main point, yeah, smoking is a huge problem. It can affect the way you get your cancer treatment. It can cause your doctor to scale back on certain treatments for you because you can't tolerate it. It makes it less safe for you to have surgery. So all reasons to try and kick the habit, at recognizing it's incredibly hard to do so.
Yeah. And we know that your chemotherapy is not as effective if you are a smoker. So think about doing all of this hard treatment and you're giving away your benefit by smoking. Doesn't make much sense. Yeah.
So while we're talking about smoking, we do have a question that says, does your risk increase with hookah and cigars?
Yes.
Yes.
Yes. Yes. Yeah. Do you know what I tell people who smoke? I say it is the equivalent of huffing on the tailpipe of your car.
Oh.
But let's make it a 1970s car where the emissions were horrible. So not your fancy car now that has low emission standards. But but that's what you're taking into your body. So the other thing, I've had people who've converted from cigarettes to cigars and some of these other like vaping things that are also highly addictive. And one of the things that I always point out to them is that the way that you smoke a cigar is very different, right? What do you do differently with a cigar? You inhale deeply. So people go, oh, I went from 2 packs a day and now I just smoke 2 or 3 cigars a day. But the way that you smoke a cigar is very different. You are still doing damage to yourself. And so I think we've got to get out of this place of trading one addiction for another.
Wow.
That is what we're doing.
One other last thing, this is a pivot, but people asked about other risk factors for breast cancer. One thing I wanted to mention is hormone replacement therapy. It is so hormone replacement therapy is something that is swung on a pendulum from being, considered God's gift to women and then being seen as poison. It is neither. Hormone replacement therapy is offered to women who are going through menopause and are suffering from many of the symptoms associated with menopause, including vaginal dryness, mood swings, potentially osteoporosis in the long term, things like that. And there's some evidence that replacement of those hormones can improve cardiac health transiently and perhaps improve osteoporosis or osteopenia. That being said, we know that it is very associated. It's definitely increases your risk of breast cancer. But there are also women who say to me, Doc, off HRT, I don't have a marriage, or I can't do my job, or I'm a miserable human being. And so, I say this only to say that you need to have an informed conversation with your doctor about the risk benefit. If you have a high family risk, strong family history, or you are known to be at high risk for breast cancer, I would be pretty loath to engage in HRT. But again, I'm not a gynecologist. I'm not a primary care physician. I think it just involves a conversation. Just don't let anyone tell you that's what you need. You need to come to that choice if it's the right one for you.
Excellent point.
So we have time for one more quick question. Is a sonogram a good tool for men, for breast cancer detection?
Yeah, so we kind of talked about screening for men and how we don't screen men because this is a rare problem. And so for a man who finds a mass, we may use several different modalities to investigate that. So mammogram is one of those, and ultrasound or sonogram is another. And so the way that an ultrasound or a sonogram helps is it helps to distinguish solid from cystic lesions. And so I would never say, oh, the only test that we need to do in your case is an ultrasound. It would be done in combination with other imaging modalities. So helpful, but in and of itself, not the only test that you would do.
Yeah, exactly. I completely agree. And, the ultrasound and mammogram are truly complementary tests. With regards to breast cancers, about a quarter of breast cancers that are seen on mammogram are not seen on ultrasound, and vice versa. About a third of mammograms that are seen on ultrasound are not seen on mammogram. So whenever someone has an abnormal mammogram, this is the case of women, we follow it up with another mammogram that's basically a closer look with magnifying glasses, and an ultrasound. We use them both together. And that's something that as men who are dealing with a new diagnosis of breast cancer should also be getting. If you don't just rely on a mammogram, don't just rely on an ultrasound, you really do need both because it helps determine not only the extent of disease, but also the best way to sample or biopsy that disease to come up with a diagnosis. Typically, things that can be seen on ultrasound can get an ultrasound guided biopsy, which is technically a little bit easier and a little bit less hard on the patient and the physician who does it. While if it can only be seen on a mammogram, people typically need what's called a stereotactic biopsy, which is a different type of biopsy. It involves being in the mammogram machine. It's a bit more uncomfortable, uses a much bigger needle. So those are kind of subtle things, again, that, don't let yourself get a short shrift. If you have an abnormal mass, you need to be getting a mammogram and an ultrasound, both at the very least.
Well, I really want to thank you, ladies. You guys have been an amazing wealth of knowledge. We've gotten into some details that I would have never guessed. So thank you guys for shedding light on this very important topic. Dr. Vance, Dr. Vanju, you are so amazing. And thank you for joining us. JJ, thank you for sharing your story. We appreciate you opening up and sharing your story with us. It's very important. And thank you guys for encouraging us all to just be our own best advocates for ourselves and for asking questions and making sure that we, that we get good answers so that we are able to advocate for our own best health. So now we are going to move on to Miss Andrea Daniels, and she's going to talk to us about one of AKA's health initiatives.
Thank you. Alpha Kappa Alpha has always been on the forefront of health program implementation, from the Mississippi Health Project during the Depression to the first sorority mammogram screening coach under the leadership of Dr. Glenda Glover, International President and CEO of Alpha Kappa Alpha Sorority Incorporated. The video you will see shows the impact the AKA mammogram coach has made in our communities.
I saw the advertisement for the mobile mammogram on the news, so I just went online, signed up, and came out to get a mammogram today.
Launched under the leadership of Alpha Kappa Alpha Sorority Incorporated International President and CEO Dr. Glenda Glover and the Excellence Administration, the AKA Mobile Mammography Unit has traveled nearly 200,000 miles, visiting 27 cities while providing almost 2,000 mammograms to African American women and other women of color in underserved communities. 10% of those getting the 3D mammogram required additional follow-up by a medical provider, proving that this service was essential.
We have a beautiful pink and green mobile mammogram unit. This is a life-saving device on wheels.
I feel so proud knowing that I am part of a sorority that is passionate about the breast cancer prevention and early detection.
Since 2018, over 1.4 million women were reached through the educational resources of Alpha Kappa Alpha chapters. This far exceeded the sorority's goal to educate 100,000 women in Target 2, women's healthcare and wellness, and specifically breast cancer awareness. Alpha Kappa Alpha has answered the nation's call to help in the fight against the COVID-19 virus. The sorority implemented a strategic outreach plan consisting of pop-up health events to provide support services and the continuation of free mammograms with several nationally known healthcare partners. Through a $50,000 grant from the Abbott Foundation, to date, AKA has held pop-up events in 10 cities, with the kickoff event in January 2021 on Martin Luther King Jr. Day of Service in Atlanta, Georgia. In addition to providing mammograms, an array of other services were offered, including free COVID-19 tests and vaccinations. Thanks to the dedication and hard work of participating chapters, a robust outreach program has yielded the following results for the pop-up events: 365 mammograms, 840 COVID-19 tests, 477 COVID-19 vaccines, 58 flu shots, 91 HIV tests, 37 plasma donations, 4 prostate exams. Empowering women through education and prevention. Breast cancer awareness is a serious matter for Alpha Kappa Alpha.
All right, everybody, you received this evening a great deal of wonderful information. We want to thank the National Panel and the Council and the doctors for presenting to you this evening. But one of the things that I want to remind you, we talked about the All of Us research program. It's important that we as a people be a part of medical research. We have to be, because right now, most of our diagnoses or our medicines are based on the average white man, which is 66 years old. So this is a call to action, to do something. If not, the first thing I need you to do is, if you're on your computer, if you're on your phone, I want you to take it out. Take it out right now and go to joinallofus.org/together and just read about what's going on and how they're trying to change the way we do health, our health. We have to be a part of this. So again, take your phones out, leave your phones out, and do it right now. Go to joinallofus.org/together. There's so much rich information. I joined because now, even though I'm the program lead for the BGLC, but this thing has become personal for me. I even went during Thanksgiving time a couple of years ago, I got my whole family and said, take out your phones and join, because this is important. This is not only important for my family, it's important for your family as well. So make a difference. Be a part of the solution. You know, we can complain all day, but you know what? We can be a part. We can stop complaining and be a part of the solution and be a champion for your own health, and your family's health and generations to come. It's going to take all of us. So we need you to be 1 in a million. Thank you.
So this has been an amazing event. Thank you all for taking the time to join us this evening for our first Black and White Table Talk. Male breast cancer, it's rare, but it's important. I hope that everyone that participated leave with some great takeaways. We're going to end this program, but before you go, we want to give you a little bit of information, and we want you to participate in the post survey. Good night.
So, let's see how you feel after learning more about the program. This is a post-activity assessment. It's given the captured data points that measure outcomes related to the program and the activity today. The assessment takes approximately 5 minutes to complete. Please scan the QR code and complete the survey. And if you haven't already today, please visit joinallofus.org/together for more information on the All of Us research program and to learn how you can change the future of health. Thank you for your time and participation.